Here, I mainly focus on introduction of coronary artery disease, hypertensive heart disease, and rheumatic heart disease. Coronary artery disease, CAD, is caused by atherosclerosis of the coronary arteries, and it is the most common cause of death in the world. The fatty material or plaque builds up along the inner walls of the coronary arteries. The narrow arteries reduce blood supply to the heart and quickly damage the heart muscles. This may disturb the function, failure, and risk arrhythmia of the heart, or even death of the cardiac muscles, infarction. The most common symptoms of CAD is chest pain, angina, shortness of breath, nausea, vomiting, etc. The coronary arteries originated from the coronary sinus of the proximal ascending aorta. The two coronary arteries are the right coronary artery, RCA, and the left main coronary artery, LMA. The LMA branches into the left anterior descending and left circumflex arteries. Coronary angiogram is the gold standard for the diagnosis of CAD. The injected contrast provides excellent resolution of the coronary arteries. This procedure can be used for both diagnosis and treatment, such as a stent in a single section. The one on your left is the normal left main coronary artery and its branches. The right one shows a local narrowing in the left anterior descending artery. However, coronary angiogram is an invasive procedure. It requires a surgical procedure called cardiac catheterization. And during this process, catheters, long-thin plastic tubes, are placed in the artery of the leg or arm and guided using an X-ray machine to the opening of the coronary arteries. Coronary CT angiography, CTA, is a heart imaging test that uses the contrast and CT scan to delineate the coronary arteries. It can be used as a screening method for those with high risk of CAD. There are a few 3D visualization tools in CTA, such as MPR, multiplanar reformation, CPR, curved planar reformation, MIP, maximum intensity projection, VR, volume rendering, and SIGN, etc., which allow the distribution of the coronary arteries to be easily seen. For example, the image on the left and in the middle are 3D VR images. The image on the right is maximum intensity projection, MIP, which shows a soft plaque in the proximal part of the left anterior descending artery, causing subsequent severe lumen narrowing, stenosis. Here is another case of CAD. The stenosis in the proximal part of LDA can be easily seen by CTA, formed by the soft plaque, which is confirmed by cardiac catheterization on your right. Although coronary CTA examination is growing in use, there are still a few limitations. Patients who have rapid and irregular heart rate is usually not good candidates for this test because image quality may be compromised. It's often not useful in patients with many areas of old, calcified, hardened plaques and stents. It needs contrast materials and involves huge radiation exposure. For those patients at high risk of CAD with typical symptoms, they should undergo coronary angiography instead of CTA. For example, this case on your left has many old and hardened plaques, and the assessment of lumen stenosis is difficult. The other two images show stents in the LAD, which also affect the evaluation of lumen conditions. Having talked about the CTA and coronary angiogram, there are two more ways that we can look at coronary arteries. MRI takes more time to get the images, but there's no radiation exposure, and it avoids the use of contrast agent. Intravascular ultrasound provides morphological features of atherosclerotic plaques. Now, we move on to another condition, hypertensive heart disease. This is one of the most common causes of death in hypertensive patients. It has become one of the leading causes of heart attack and stroke. Uncontrolled and prolonged elevation of blood pressure can lead to the development of left ventricular hypertrophy, coronary artery disease, various conduction system disorders, myocardial dysfunction. Complications include congestive heart failure, arrhythmia, or myocardial infarction. Routine chest X-ray has a role in the detection of left ventricular enlargement for patients with hypertension. The image on the left is the normal. For the case of hypertensive heart disease, typically, the ascending aorta projects far to the right, and the aortic knob is enlarged. The left heart border is displaced laterally and inferiorly. Echocardiography is clinically useful in the assessment of left ventricular structure and function. This image on your right demonstrates marked concentric LV hypertrophy. Dr. Chiu will cover echocardiography in more detail. The last topic we will talk about is rheumatic heart disease. This condition is uncommon in developed countries, but still be seen in underdeveloped regions. Rheumatic heart disease is a condition in which rheumatic fever causes permanent damages to heart valves, almost always the mitral valves. Mitral stenosis is involved in 99.8% of these patients. The most common symptoms are from left heart failure, such as shortness of breath or exertion. Understanding the hemodynamic changes of mitral stenosis is helpful for the identification of radiographic findings on chest X-ray. Mitral stenosis obstructs blood flow from the left atrium. This will lead to the left atrium overload and dilation, while left ventricular underload causes atrophy and small aorta. On the other hand, in order to maintain left ventricle filling across the narrow valve, left atrial pressure goes up, causing left atrial hypertension, and consequently, increased pulmonary venous pressure, pulmonary venous hypertension develops. In such condition, upper lobe vessels become as large as or more prominent than the lower lobe vessels. With prolonged elevation of pulmonary venous pressure will eventually lead to pulmonary arterial hypertension and right ventricular hypertrophy. Therefore, mitral stenosis has effect on both the heart and lungs. Its typical imaging findings on chest X-ray include cardiomegaly, enlarged left atrium and right ventricle, pulmonary venous hypertension, pulmonary arterial hypertension, dilated pulmonary trunk, and small aortic knob. Previously, we have already studied the section of normal cardiac contours and cardiomegaly and pulmonary vascular patterns. They are the basis for you to recognize the typical imaging findings of heart disease on chest X-ray. Here is a typical case of chronic mitral stenosis. The frontal chest radiograph on the left demonstrates a cardiomegaly, with cardiothoracic ratio is 0.6. Enlarged left atrium can be seen, which is evidenced by the double right heart border. Enlargement of LA appendage and posterior displacement of a barium-filled esophagus on lateral view. Pulmonary venous hypertension produces a redistribution of flow in the lungs, so the upper lobe vessels are more prominent than in the lower lobe. Pulmonary arterial hypertension is characterized by the dilation of pulmonary trunk, an enlarged right ventricle, as evidenced by the retrosternal fullness of the lateral view. Putting all this together, mitral stenosis can be diagnosed. These changes are relatively specific for rheumatic heart disease and is rarely seen in non-rheumatic mitral disease. This is another case of chronic mitral stenosis. Frontal chest X-ray shows typical imaging changes of both the lungs and heart. CT image on your right shows calcium deposited in clumps on mitral valve leaflets. Echocardiography is the preferred modality for the diagnosis and follow-up of heart disease. It's very good to actually see the actual internal structures and motion of the heart during cardiac cycle. Dr. Chu will introduce more on it after me. That's all for this session. Here are take-home messages. 1. Identify normal and abnormal cardiothoracic anatomical structures demonstrable on the chest film. 2. Correlate hemodynamic changes of MS with its chest radiography findings. 3. Recognize the radiographic signs of CAD, hypertension, and MS. These are useful learning resources you can reach to. Thank you very much.